First, I've enjoyed everything thus far. This has been a wonderful conference. I want to thank everyone for their presentations, and I hope that I don't bore you now as I begin to present. I'm also, for those of you who were here at the beginning, know that we dealt with a storm, and so I'm having some Wi-Fi issues. So I hope you all will excuse me if I turn my camera off to make sure that I do not lose Wi-Fi, but I'm going to share my screen now. And, or no, it seems to be up. If we have issues, I'll turn my camera off. And I'll give you a little background as to where I am. Yes, my name is Cecily Jackson. I'm in the Doctorate of Healthcare Administration program here at Franklin. And I currently serve as Director of Grants and 340B programs for a federally qualified health center and certified community behavioral health center here in Alabama, which leads me to my areas of interest in public health for our underserved and unserved communities, and why I would like to discuss kind of an alternative methods or proposed methods for saving the 340B drug pricing program. So as we go on this evening, I'll discuss pretty much the what, the when, the why, and the how of the program and what we can do to save it. So first, what is the 340B program? And this may be of interest because some people may not be aware. The 340B drug pricing program came out of the 1990 Medicaid drug rebate program. Prior to that program being enacted, certain manufacturers would give special consideration to providers who provided care for indigent and underserved populations. And they would make their medications available at decreased costs so that these institutions or providers could take care of this particular patient population. When the 1990 Medicaid Drug Rebate Act, rebate program came into being, it did away with a lot of these rebates for these provider types. So in 1992, Congress enacted Section 340B of the Public Health Service Act to allow these providers to again obtain these reduced cost medications to serve their special patient populations. They also hope that by enacting this program, it would allow these providers another revenue stream in which to provide resources to their patients. To give you an example of what they meant by this revenue stream and what they were hoping was that your average pharmacy, let's say Walgreens, CVS, or something like that, is able to purchase a medication. I'll take Farxiga, which is a diabetes medication, are able to purchase this medication at an average cost of $350 at what's called wholesale acquisition cost. The average insurance reimbursement, Blue Cross Blue Shield, Medicare, United Healthcare, is about $500 for this medication. So the CVS's and Walgreens of the world have a margin of $150. The special providers who are eligible under the 340B program are able to purchase this medication at a reduced cost. In the case of Farxiga, certain formulations of Farxiga, they're able to purchase it at 30 cents as opposed to $350. So you see that margin is much greater, almost the full margin of $500. But what they're expected under the law to do with this margin is to take it and provide charitable care or provide services for those patients who are uninsured or who could not afford the medications or other services otherwise. It's noted that this differential or this margin differential has been the source of a lot of research and a lot of debate. So what is the problem and when did it occur? Well, to give some background on this, We have this brief timeline here. As I stated, the Medicaid rebate program came into being in 1990. The 340B program came into being in 1992. Then in 2003, there were regulations added, which allowed disproportionate share or DISH hospitals a greater opportunity to participate in the program. There's a certain calculation that determines which hospitals are considered DISH hospitals and if they're able to participate in the program. Then also in 2010, we know we had the Affordable Care Act that was enacted, and it also added additional provider types that were eligible for the program. So this is just a brief rundown of the different provider types categorized in two ways. As grantee types, most of them came into being in the program between 2003 and 2010. And then the hospital types, disproportionate share, children's hospital, critical access hospital, and rural hospitals. Most of these providers types, as you can see, provide services to indigent patients. So to put this all in perspective, when the program began in 1992, you had 90 provider types, or 90 providers, not provider types, 90 providers that were participating in the program. By 2005, you had 591 providers participating in the program. And in 2017, Barlas noted in his research that there were upwards of 12,000 provider types participating in the program. So as you can see, over this period, the program has grown exponentially. However, other aspects of it have not, such as oversight and regulation of the program, which leads us to where our problem came in. There were several researchers who looked at the program and wondered, was it truly meeting its intent? And that prompted the Department of Health and Human Services, Office of Inspector General, and the Government Accounting Office to investigate. During that investigation in 2015, it was found that there were several types of entities that weren't necessarily using their revenue margin to provide care for charitable, in a charitable manner for underserved patients. As a matter of fact, Barlas and Traynor, both in their research in 2018, noted that the Medicare cost share paid by patients was actually higher than what the providers were paying for the particular drugs. So sometimes the providers were making a profit off of the patients that they were actually supposed to be serving. So why is this important? Well, first and foremost, this is a public health issue. The US, as we know, pays more per capita for healthcare than any other OECD member nation. However, we have some of the worst outcomes. Additionally, as was noted very, very recently during the pandemic, when indigent patients are unable to find regular care, they utilize emergency departments, and our emergency departments become stressed. There were reports showing that there were patients who did not have COVID symptoms who were using the emergency department and keeping other patients with true emergencies out of them and causing harm. Additionally, the 340B program revenue for some organizations, particularly grantee organizations, such as Ryan White HIV/AIDS programs and clinics, community health centers, and federally qualified health centers, require that revenue to make their operating budgets or keep their operating budgets in the black. It was noted by Kate and Nick Pay that some of the Ryan White programs, the revenue from the 340B program makes up anywhere from 30 to 70% of the operating budget for many of the Ryan White programs or the AIDS drug assistance programs. And for many federally qualified health centers, the 340B program revenue makes up approximately 30%. Most of these programs, again, other than revenue they make from the 340B program, rely on federal grants to keep their programs open. So how can we fix this? Well, there's been some research on this to figure out what's the best way to do it. Research as well as some suggestions from other stakeholders, mostly manufacturers and insurers. There's been a big push as of late to just do away with the program altogether. Others say that the 340B program, for those providers who get discounted medication through the 340B program, that the reimbursement that they get for their insured patients should be reduced. So instead of that large margin that we saw on the drug Farxiga being at almost $500, that maybe they should only receive 50% of that. Another proposal that has been made is to not allow upfront discounts, but actually require the providers to pay the wholesale acquisition cost and then request a rebate on the back end. And then the last is to require safety net providers to disclose their 340B derived revenue, which is actually one in which there's a lot of research regarding, and is the proposal that I would like to set forth in the research that I have found too. So some of the proposed reforms that have been put out there are: one, increasing funding for the Office of Pharmacy Affairs. The Office of Pharmacy Affairs is in the Department of Health and Human Services, and they're tasked with the oversight of the 340B program. Since 1992, the Office of Pharmacy Affairs has worked with a staff of anywhere from 16 to 20 personnel. Well, 16 to 20 personnel to oversee 90 participating providers was fine in 1992, but research has shown that they've been unable to keep up with the growing number of providers in the system. So there have been some concerns about how well the system is being properly managed. Secondly, there's a discussion of creating a public disclosure system. So one of the researchers in the program, and I forgot to put my notes here on in my notes here, suggested a public disclosure system similar to what many hospitals have had to do as of late, disclosing their charge masters on their website for patients to view. If you're not familiar, if you go and pull up a hospital, the website of a hospital in your community, they have to disclose their fees for a majority of services. This is now required because they were concerned that indigent patients were being overcharged for certain procedures. And a system similar to this may help to see how these particular hospitals and these particular entities are using their 340B revenue to help their indigent patients. Coincidentally, researchers have shown that this is a workable system, given that your grantee providers, such as Ryan White clinics, community health centers, federally qualified health centers, rural health centers, are all required to already disclose how much 340B revenue they generate and how they use that revenue to support the work for their underserved populations. Then another proposal in the research is expanding the audit process. Well, this relates back to increasing the funding for the Office of Pharmacy Affairs. So you can imagine if you have 16 employees and they actually haven't had an increase in funding either over the last 30 years. 16 employees who are now required to oversee 12,000 different providers, that there are some audits that fall through the cracks. And this has been an issue, and this is something to be considered. Some of the other research options were, as we noted on the previous slide, was reducing the reimbursement amount for the 340B eligible providers. This option will probably not come to fruition, as of last week, the Supreme Court overruled the Centers for Medicare and Medicaid Services plan to reduce reimbursement for 340B eligible providers. So one thing to remember in closing is that our ultimate stakeholder in all of this is our patient. And whatever decision is made, we have to make sure that the patient is first. We are looking at the patients who are to benefit most from the 340B program are an at-risk population. And whatever is done, we must make sure that this at-risk population is taken care of. While we know that Ryan White clinics, FQHCs, and AIDS drug assistance programs rely heavily on the 340B revenue, it's important that whatever systems are in place do not limit their funding opportunities in a way to continue to promote or provide services to these particular patient populations. So these are some of the resources or references that I addressed in their research in this presentation. And at this point, I will stop and see if there are any questions, or if there are any questions that don't want to be asked now, you can ask me in an email.
Hi, Cecily, this is Leah. That was a great presentation.
Hi, Leah.
And I'm hoping that everybody's still with us, because I also work in 340B with the Ryan White program. You know, one of the things that I find really interesting about the 340B is that it really highlights exactly how much money the pharmaceutical companies and insurance companies are making off of patients. So, and just from the amount you referenced drugs that were a great highlight of what the costs are. I can tell you that as somebody that runs a Ryan White 340B out of, say, 500 patients, through our 340B, we could be bringing in close to $30 million a year easily, and we have a very small program. I do think it would be a really good idea if they kept the legislation that you have to account for where it goes. Accounting for where it goes is a really good way of showing exactly how that money is being used, and making sure that it doesn't all go to benefits for executives. Right now, the way it's written, particularly for FQHCs, there's no restriction. I think Ryan White is one of the only ones that are restricted to spending it along the lines of your grant. Right. Do you see that happening? Do you see a pathway for the 340B program to be actually showing the transparency of where all of that funding is going?
I think it would be, and I think that's where the research is that there needs to be more transparency in this. As you stated, Ryan White programs and ADAP programs are explicitly required to divulge where the revenue and how the revenue is reinvested. FQHCs do that, but it's not explicit. They do that through their UDS reporting and their CMS, their Medicare cost report. I couldn't think, the Medicare cost report. So it's not explicit. However, it is, because I do that section of the UDS report every year. So you have to account for your revenue, and you have to account for where that revenue was spent. So it's not, unless someone's going to dig into the UDS, and most people don't unless they're doing research, you really don't see it. However, hospital entities, other than the Medicare cost report, and all they have is a check mark that says they are providing this charitable care. They don't have to give the detail. And that's where the researchers are saying that the hospital entities need to have a system where they're giving the same type of detail that Ryan White and FQHC are required to do, and then come up with a universal system among all of the entity types. Granted, it would create more reporting, as if we don't have enough reporting to do. But I think that would, I won't say satisfy, but kind of put some of the manufacturers and insurers kind of ease some of the tension. Because as we know, you and I both know, we could have a whole day conference, which there are, and I'll be going to one in a few weeks, on just what the manufacturers and the insurance companies do to restrict or try to restrict the program, and how it in turn, unfortunately, ends up hurting our patients. In Atlanta, there was a Ryan White Center that closed when they lost some of their revenue after the Gilead change. So there was, this is proof that they need this revenue to stay open to help their target populations.
A great example of that is the 340B program funds all of the staff salaries, and then all of the care that's provided is provided for free because it's already paying for the staff that are there, and it pays for any expensive lab tests that have to be done. And that's really how it should work. It doesn't surprise me that that program folded. Is this what your dissertation is on?
No, actually it's not, but it probably should be because I do so much work on this every day.
Yes, this would be great.
But I'm just more on patient care access. And of course, the 340B does play into that, because if you do not have the funds to provide the services and cover, as you say, the salary for the staff, you can't have access for these patients in these particular clinics. So.
Yeah.
Latanya,
awesome.
Do I see?
I'm gonna
Oh,
get
I'm
out.
Sorry, Leah. I didn't mean to cut you off. I'm sorry.
No, I was just gonna say that was an awesome presentation, and I'm gonna clear the way for somebody else to ask you questions now. Thanks, Cecily.
Latanya, did I see your hand raised? You're on mute now, though.
So again, I do not have a question. I just have a statement. You absolutely knocked that out of the park. Great
Thank you.
presentation. And I have learned something about a new subject. I also want to give you your accolades in closing. You did an awesome job presenting and leading today's agenda for the conference, Dr. Pio, and just the DSA committee as a whole. Lots of great information a lot of great information was presented today. So thank you all.
Yes, thank you for your input and for keeping us going as well, Latanya, and for all you have done for the DSA and continue to do.
Nothing in comparison to you guys, but thank you.
Are there any other comments, not necessarily on my presentation, but on all the wealth of knowledge that has been shared this afternoon, this evening? Dr. Raymond.
Actually, I was going to type in a comment and I clicked the wrong button, but I concur. This was just a really engaging session, and looking forward to tomorrow. And thank you, everybody.
But thank you, Dr. Raymond, for your attendance. And I see Dr. Stevorn has posted great session tonight, and he looks forward to seeing everyone tomorrow. And with that, Ella, were you going to come back and bring us any remarks? I didn't want to steal your thunder. Nope.
No, Cecily, I have no thunder. I'm just in awe of being a part of this. Thank you so much for your hard work, for all of the organizers for this. As a student who also has a huge gap between my master's degree, which was of course in person, and now joining this virtual learning community, I will say that this has been more than what I anticipated, and I greatly appreciate it all. I will ask a question regarding your 304B. Are there no caps in place for any of the provider or I'm sorry, the only word that I can think of is profit. Are there no caps in place for providers so that those costs are not incurred by those uninsured and underinsured patients?
So there are provisions, and this is truly just a brief overview. To
Okay.
give a little insight, there is a 340B Advanced Certified Expert certification. I do hold that certification. It took me 7 months to obtain it, and for some crazy reason, I did it while I also did my first year here at Franklin. So I don't know what I was thinking, but well, I do know what I was thinking. My employer was paying for it, so that's why I was trying to do it. So that gives you some idea of how in-depth the different program is. And most of my work is in the grantee space, not the hospital space, which is much more involved. But to that your point, there are safeguards and programs in place to make sure that the benefit is truly for the uninsured and underserved patient. The problem is what they were finding, and what's really documented in the literature, and you'll find more research about this than any other topic, is the fact that there have been loopholes. There have been loopholes in the regulations that actually technically there has not been any more regulation since 2010. What has happened is the Department of Health and Human Services has put out guidance, and guidance, for those who don't know, is not as enforceable as regulation and statute. So that's where the problem is, and where there are legal challenges. There are legal challenges right now, as I stated, with the Centers of Medicare and Medicaid Services and the particular 340B hospitals. There are legal challenges right now with the drug manufacturers and all of the entity types. There are legal challenges right now between the different entity types and the Department of Health and Human Services. So there's a lot going on. Well, technically, let me go back. The entity types can't sue the Department of Health and Human Services. There are 8 representative groups, or such as the National Association of Community Health Centers, who are suing on behalf of these entity types. With the Health and Human Services, because there has been a pushback. I'll just share in a meeting I was in recently, because of some of these challenges, some of these centers have lost as much this year alone, about 20 to 30% of their 340B revenue, which is negatively impacting their operating budgets. There's some centers that had weekend services are no longer able to offer weekend services. So that's where a lot of this comes in, and why researchers have shared, based on their research, alternatives to save the program, so that we don't, so that our patient population doesn't lose out. I'm sorry, I hope I answered your question in all of this roundabout way.
You did, and thank you very much.
Yes. Well, with that, everyone, I think this is a good place for us to take a moment and say good night and have a rest, and reconvene tomorrow at 10 a.m. for day 2.